Hey guys, Dr. Eli Freiman. I'm a pediatric emergency doctor, and I know I've taken a bit of a hiatus since my last video because, to be honest, editing YouTube videos is kind of a drag. I'm going to try a more short form version and see if people like this format instead. I'm going to talk to you guys about a case that I had in the ER this week, and we're going to play at it a little bit differently. Instead of me just sort of telling you what happened, I'm going to present a patient like I would expect a medical student to present it to me. And we're going to walk through my thought process in taking care of that patient and how we ultimately got to the correct diagnosis. So let's dive into the case. We had a teenage patient who came in at the beginning of one of my shifts, and their chief complaint, meaning the main reason why they came into the ER, is because they just didn't feel well. They said that they were having headaches, they were a little bit nauseated, and boy, did their muscles ache a whole lot. Right off the bat, before you even go in and see the patient, it's our job as an ER doctor to start thinking about what's called a differential diagnosis. What could be going on with this patient, and what are the diagnoses already brewing in the back of my mind that could help explain these patients' symptoms? There's a lot of things that could cause headache and nausea and muscle aches. Are they sick with the flu? Do they have a migraine? Is this heat exhaustion? Are they dehydrated? So many different things. And before I even go into the room, I already have that list of ideas in my mind. So when I get into that room, I ask tailored questions to the patient's complaint. And I do a physical exam that, frankly, isn't as comprehensive as what they teach you in medical school, because that's like 200 points. I don't have time for that as an ER doctor. Instead, I go through what are the most high yield things on exam that I'm looking for to take care of this patient. Of course, everything starts with a good history. So you get in the room and you start talking to this patient. What happened? Well, it turns out that they're a distance runner, and they had just finished a long run, a race actually. And at the end of the race, they started feeling really crummy. So they came into the ER. Now, right away, that changes my differential diagnosis because they're not having fevers, they're not having flu symptoms, so it's probably not the flu. They're not vomiting, so it's not a stomach bug. And that's a pretty typical, or atypical rather, way for a patient to start complaining of a migraine. But there are a couple things in the back of my mind I'm considering, and I'm wondering if you can think about what they are. So I start asking this patient more questions. What did they drink on the run? How did they hydrate? What was their nutrition? How far did they run? How hot was it out? What was the humidity? And how are they feeling now? Because anytime endurance runners come into the emergency room with similar complaints, there's a couple specific diagnoses that we think about that you really can't miss. So then we do our physical exam. And on exam, actually, the first thing that struck me is that this endurance runner seemed a little bit more tired than you might expect. Sure, if they had just run 8, 10 miles, you'd expect them to be a little bit tired, but not tired like falling asleep tired on the stretcher tired. Not so much that you need to almost rouse them a little bit to answer questions type of tired. That type of tired is a little bit unusual. So I asked this patient, how far did you run? Well, they actually ran almost 10 miles. Okay. And what did they drink? Well, they drank water. What else would they drink? Okay. And how hot was it out? Well, it was only about 75 degrees. Okay. After that, you get into the meat of your physical exam. And I tell all of my medical students that physical exams really consist of three parts. What are their vital signs? How do they look on general appearance? Do they look really sick? Do they look tired? Are they alert and happy and texting on their cell phones? And then you actually do a head-to-toe exam and try to see if there's anything on your exam that you expect. Again, I have a differential diagnosis going into this room. Or are there things that you don't expect that might lead you down a different pathway? Okay, so the patient's vital signs, most notably, were normal for temperature, respiratory rate, and blood pressure. And the reason why that's important is because one of the things I was thinking about in my differential diagnosis is this heat exhaustion. Was this patient overheating to a degree where their body could no longer regulate their body temperature? And those patients come into the ER typically a little bit on the warmer side. If they get into the heat stroke territory, they can be quite hot, actually, 104, 105 degrees Fahrenheit. But that wasn't this patient. They had no issues breathing, they had normal oxygen, normal blood pressure, that was good as well, but their heart rate was elevated. It was about 110, which for a teenager who is no longer exercising is too fast. Not horribly fast, we're not talking like arrhythmia territory, but certainly faster than I would have expected. Okay, that's step one. Step two is the general appearance. The patient looked a little bit more tired than I would expect. I know they're an endurance athlete and you'd expect them to be tired after running a race, but not this tired. The patient was, dare I say, lethargic to the point where you almost feel like you had to arouse them or remind him to wake up to answer questions, which is a little bit unusual, specifically for a trained endurance athlete after a race. So that struck my interest as well, is that their general appearance was just a little bit off. Their head to toe exam was actually not that impressive. One of the things I always focus on is their hydration status. I look in their mouth, their mucosa, their mucous membranes, and see if they're dry, cracked, or whether they're regular. Drooly? They have lots of saliva, wet, moist mucous membranes is what we write in our note. Sorry for using that word. Um, and this patient's mucous membranes were definitely a little bit on the drier side. They weren't parched, weren't cracked, but were on the drier side, which started to make me think, okay, could this be dehydration? And then you move through the rest of their exam, and frankly, it was okay. Their heart and lung exam were normal, their belly exam was nice and soft, their skin exam didn't show any rashes, a good skin turgor, which we don't honestly check for in the ER. But the next thing was I started pressing on their muscles, arms, legs, and what I noticed is that their leg muscles were really, really, really sore. Okay, that is something that we pay attention to. So it's now my job to walk out of that room and say, all right, let's synthesize all this information. I have an endurance athlete who came in after running a decent number of miles, but for an endurance athlete, not that many, on a warm but not hot day, who came in with headaches and nausea and muscle aches, normal-ish vital signs except for some tachycardia, some fast heart rate. And then on exam, really was sort of borderline lethargic, which is not usual for endurance athletes even after a race, and maybe looked a little bit borderline dehydrated and had sore muscles. It's my job as a doctor to know, okay, what are the common things that do this? What are the uncommon things that do this? And then what are the don't misdiagnoses that do this? And then what do I do about it? So I'm going to pause for a second, give you a minute to think about what you think might be going on and what you would do about it. Because here's what I was thinking. The most common reason why someone would come into the ER with those complaints is that they're dehydrated. They've ran an endurance race, maybe they didn't have enough water and they're just feeling dry. And that's why they're fatigued and they have headaches and maybe feel a little bit nauseated. That's true. But that wouldn't explain the muscle aches. So we start having to think about, is this more than just regular muscle aches? Is this muscle damage? Do we need to think about something called rhabdomyolysis, which can happen even in endurance athletes if they push themselves too hard, too far, too fast, or too dehydrated? You can get muscle enzyme breakdown, and that muscle enzyme gets into your blood. It can affect your kidneys and actually cause kidney damage, and is one of the can't miss diagnoses in the ER. So that's something that I'm thinking about. But there's something else that I was evaluating for that had to do with the fatigue that was out of proportion to what you might expect. And I'm not going to tell you right away, but I will say that it requires a blood test to diagnose, typically. So when I walk back to my station now, it's my job to think about, what do we do with this patient? Because it's not only enough to know what I think is going on, you have to decide what to do about it. For sure, this patient needs an IV. They need IV fluids because chances are, no matter what's going on, a little bit of IV fluids are going to help them feel better. But it's also my job to make sure that there's nothing scary going on their labs. So yes, I'm going to get blood counts. I'm going to get electrolytes, and I'll tell you why. And then I'm going to get a muscle enzyme test called creatine kinase, or CK, to evaluate for rhabdomyolysis. But there's two other tests that I'm going to get as well to make sure that I don't miss any of these don't miss diagnoses. Can you guess what they are? First and foremost is an electrocardiogram. Any patient who comes into the ER with any combination of dizziness, fatigue, or any related symptom gets an electrocardiogram. It's unusual in an endurance athlete of this age to have a heart rhythm issue or, God forbid, any injury to the heart, but we're not missing that. So you get an EKG every time, no matter what, if someone comes in with similar symptoms. The second thing is actually a urine test. And I wonder if you might think why I would get a urine test. The answer is, I just told you that rhabdomyolysis can affect the kidneys. And if you're going to have kidney damage, or if you're going to pee out that creatine kinase that your muscles released when they got damaged, you can see that on a urinalysis. So you're looking for a couple of things. Is there excess protein in the urine? Is the urine overly concentrated? And is there a false positive blood on the urine dipstick? This is one of the most fascinating things we always teach med students. If your urine dipstick shows that there's blood on it, meaning that when you literally dip the test indicator into the urine, it comes up positive for blood, but then you actually look at the urine under the microscope called the microscopy or the urine sediment, you'll see that there's actually no red blood cells. And you might ask, well, how do you have blood on the dipstick, but no red blood cells on the microscopy? And the answer has to do with the myoglobin that's released from injured muscle that actually interacts with that test to trick it into thinking there's blood, right? Myoglobin sounds a lot like hemoglobin, which is, of course, one of the main components of your blood cells. And hemoglobin and myoglobin react the same way on this test. But boy, you look under that microscope, no red blood cells. So this patient gets a UA. They get a UA, they get electrolytes, they get a CK, and they get an electrocardiogram. And can you guess what I found on the electrolytes that confirmed my diagnosis this whole time? It was a low sodium level. This patient had what was called runner's-induced hyponatremia. And what that is, that when endurance athletes typically hydrate during a run with water only, you can actually dilute out your electrolytes. If you drink enough water, but don't take electrolytes with them, either through food or through electrolyte sports drinks or any other electrolyte drinks like Liquid IV or Pedialyte or Gatorade or Powerade, something like that, you can literally dilute out the electrolytes in your blood. And these patients come into the ER with low sodium or hyponatremia. And what's different about these patients' presentations is that they typically have more of an altered mental status picture than you would expect in some of these athletes, right? They just ran 8 miles. He's an endurance athlete. He shouldn't be that tired. Not falling asleep on the stretcher, can't talk to me tired. But if your sodium's low, it can cause headaches, nausea, altered mental status, and if untreated, can actually lead to seizures, coma, death, the whole triad. So it's one of those don't miss diagnoses in the ER. The good news is that it's easily treated, right? You give them salt supplementation, you give them IV fluids with extra salt in them, you make sure that they're eating something. And by the time this kid left the ER, he was feeling so much better once that salt was replaced. No, he didn't have rhabdomyolysis, his legs were just sore, but we found the critical hyponatremia that ultimately may have saved his life. So, takeaway, if you have an endurance athlete who comes into the ER who just seems more fatigued than you think, and they were running on a hot day, they were sweating a lot, maybe pounding water, but that's it, you have to consider running-induced or exercise-induced hyponatremia, which is a little bit of a misnomer because it's really not the exercise that does it, it's the taking too much free water that does it and can lead to a life-threatening illness if not identified. That was my interesting case this week in the ER. I hope you liked it. Thanks for tuning in, and I'll see you next time.